Sí.
Thank you. I'm in very bad condition because before me, Professor Kilic talked about this area. But although there is also for the surgeon some time, and the surgeon says that the aortic valve replacement coronary bypass should be done at the same time. So let's see the impact of the disease. Next slide, please. Εγώ το προχωράω. Συγγνώμη. We know already that more than 50% of patients with severe aortic stenosis have coexisting coronary artery disease. In the next slide, we see also a good study from Scandinavian countries that we see that after the age of 65, there is severe aortic stenosis only to 1.3, and after 75 years old, 2.8. At the same time, there's much higher incidence of coronary artery disease, which grows to more than 26% after the 80 years of age. When we see the pathophysiology and critical aggressive factors, we see that the age is the main condition, the gender, because the men are more than women, high blood pressure, elevated lipid levels, diabetes, chronic kidney disease, and smoking. Most of the patients could be asymptomatic, but some of the patients have angina pectoris, usually presenting patient coronary artery disease. And third, the patients with severe aortic valve stenosis may present due to low oxygen delivery and impaired coronary microcirculation. We don't propose the patient other exams that CT angiography and saphenography, classical. After that, we have to select the patients. We see the age of the patient, the associated diseases, diabetes, renal failure, respiratory failure, and we see also the syntax score. The syntax score is most important risk because low-risk patients could proceed with a TAVI procedure. The intermediate risk patient or high-risk patient should be done aortic valve, SAVR, and also coronary artery disease. The surgical risk is most important from all this because if there are multivalent disease and we have to do a long cross-clamp duration, we don't have very good results. Or possibly we don't have very good complete perfusion, which is a critical statement. And after that, the severity of coronary artery disease is the main problem. When we see the operated patients, the 1-year mortality study says that the bleeding is the more prominent score. After that, the myocardial infarction, major vascular events, renal failure, or placement of permanent pacemaker. In all the studies I have seen, all these studies have an algorithm which says TAVI and PCI, and after that, we have also the same manner to see the patients, which means the exact things. A small quantity of these patients proceeds to CABG and SAVR. The big quantity of these patients goes to the PCI and TAVI, or TAVI alone. In the next slide, we see also that in the center there is the study of the patient. And around this, there is the heart team. What means the heart team? The heart team means that a group of cardiac interventions and also surgeons come together and see each patient, which of them goes to TAVI and which of them goes to SAVR and coronary disease. Where the surgical treatment excels? First of all, complete myocardial perfusion is better than with coronary artery vascularization, especially with these patients with limited LAD. They found that if we are doing PCI to circumflex or right coronary artery, they don't have very good results for a long time, more than 5 years. From studies to date, longer survival after coronary artery disease and revascularization. In patients with acute coronary syndromes and patients with multiple calcified valves, we have very good results. And there is lower likelihood permanent pacemaker placement. After that, I cannot see which of them goes better than PCI and TAVI or SAVR and coronary artery disease, but circulation in December 2024 said that the patients with SAVR and coronary artery disease have shown to have good long-term outcomes, although periodontal risk is increased. The therapeutic approach of PCI and TAVR is still unconfirmed. Thank you for your...
Thank you very much for your presentation. So I think difficult cases are difficult for both strategies, and easy cases are easy for both strategies. So we need to find very tiny difference between the modality we use each time in order to give our patient the best result.
First of all, thank you very much, Mr. Spargis and the organizing committee, all the speakers. As I see